Welcome to our second video on infections of the respiratory tract. We will specifically cover pneumonia. Let's begin. The topics included in our discussion on pneumonia are introduction, classification, community-acquired pneumonia, its clinical features, diagnosis, treatment, complications, and prevention. We will also discuss hospital-acquired pneumonia, ventilator-associated pneumonia, and aspiration pneumonia. Pneumonia is an infection of the lung parenchyma. The inflammatory response in pneumonia classically leads to leakage of edematous fluid into the alveolar spaces, so alveoli become filled with fluid known as consolidation of alveolar spaces. However, in some cases, inflammation is confined to the interstitial spaces of the lung parenchyma, which, as we'll discuss later, happens in atypical pneumonia. Pneumonia is mostly acquired by inhalation of respiratory pathogens, so inhalational spread is the most common mode of transmission. Rarely, hematogenous spread from distant foci of infection also occur. There are various types of pneumonia. Based on etiology, pneumonia can be divided into bacterial pneumonia, if caused by bacteria such as Streptococcus pneumonia and Mycoplasma, viral pneumonia, if caused by viruses such as influenza virus and adenovirus, fungal pneumonia, caused by fungal infections such as histoplasmosis and coccidiomycosis, and parasitic pneumonia, for example, the pneumocystis pneumonia of AIDS. We may also hear of pneumonia classified as lobar pneumonia, bronchopneumonia, and interstitial pneumonia. This is based on the anatomical pattern of involvement of lung tissue. Lobar pneumonia is said to occur when consolidation involves an entire lobe. Bronchopneumonia occurs when the inflammation is centered on bronchi, that is, peribronchial inflammation leading to patchy consolidation throughout a lung field. Interstitial pneumonia occurs when inflammation is confined to alveolar septi only, seen on a chest X-ray as diffuse reticular or ground glass opacities. Here's an image showing lobar pneumonia on the left side, affecting all the right middle lobe of the lung, and bronchopneumonia on the right side, seen as patchy consolidation. Another popular classification of pneumonia is by dividing it into typical and atypical pneumonia. These differ in terms of their clinical presentation and causative organisms. So here's a table showing differences between atypical and typical pneumonia. Typical pneumonia is caused by typical bacteria pathogens, most commonly Streptococcus pneumonia, Staphylococcus aureus, Haemophilus influenza, and Klebsiella pneumonia. It presents with an acute onset of classic pulmonary symptoms of pneumonia that include dyspnea, productive cough, fever, and pleuritic chest pain. In contrast, atypical pneumonia is caused by atypical bacteria pathogens such as Mycoplasma, Chlamydophila, Legionella, viruses such as influenza, adenovirus, RSV, CMV, or fungi. It presents with an indolent onset of atypical symptoms such as headaches, fatigue, malaise, and dry cough. Oftentimes the symptoms are mild and do not bound the patient to bed, giving it the name of walking pneumonia. Atypical pneumonia can also present with extrapulmonary symptoms, for example, the gastrointestinal and CNS symptoms seen in Legionella pneumonia. Another difference is that the pathogens of typical pneumonia are usually visible on gram stain, whereas those of atypical pneumonia are usually not. This is due to their atypical characteristics, for example, the absence of cell wall in Mycoplasma and the intracellular locations of Chlamydophila and Legionella. Consolidation of alveolar spaces is seen in typical pneumonia, so it commonly manifests as lobar or bronchopneumonia. In contrast, inflammation is confined to alveolar septae in atypical pneumonia, so it produces the pattern of interstitial pneumonia on chest X-ray. Lastly, in typical pneumonia, penicillins are often effective, whereas in atypical pneumonia, penicillins are ineffective because of either the absence of a cell wall or lack of an extracellular location, characteristics required for penicillins to be effective. So the first-line drugs to treat atypical pneumonia is macrolides, which are protein synthesis inhibitors and do not require cell wall or an extracellular location. Another common way of classifying pneumonia is to divide it into community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia. This is based on whether one acquires the infection in the community, in the hospital, or because of intubation, respectively. Now let's discuss community-acquired pneumonia in detail. It's defined as pneumonia occurring within the community or within the first 48 hours of hospitalization. The most common cause is Streptococcus pneumonia, which, as mentioned already, causes typical pneumonia. Other common pathogens causing typical community-acquired pneumonia are Haemophilus influenza, Moraxella catarrhalis, Staphylococcus aureus, and Klebsiella pneumonia. The common pathogens of atypical community-acquired pneumonia are Mycoplasma, Chlamydophila, Legionella, and viral pneumonia. Fungal pneumonia is also a rare cause of atypical community-acquired pneumonia.
Let's quickly go through some important features of the commonly encountered pathogens in community-acquired pneumonia. These clinical features can help identify the bacterial pathogen and help in selecting empiric antibiotic therapy without the need for definitive diagnostic testing. Okay, so starting from Streptococcus pneumonia, it is the most common cause of community-acquired pneumonia and produces features of a typical bacterial pneumonia. So in patients presenting with symptoms of typical pneumonia, Streptococcus pneumonia always has to be kept in mind and treatment is to be given accordingly. Rusty sputum is classic for Streptococcus pneumonia. Staphylococcus aureus is especially known for causing secondary bacterial pneumonia post-influenza. Recall from step 1 that it's a highly virulent organism and, not surprisingly, causes a severe necrotizing pneumonia with a high mortality. Haemophilus influenza is also a common cause of community-acquired pneumonia and is particularly common in elderly and those with underlying lung disease, for example COPD. Klebsiella pneumonia, similar to other gram-negative rods, is typically a cause of nosocomial pneumonia. It's mentioned here because it's also a frequent cause of typical community-acquired pneumonia in alcoholics and diabetics, basically those with risk of aspiration. It classically produces a current jelly sputum. Coming to atypical organisms, Mycoplasma species is the most common cause of atypical pneumonia. It's mostly seen in young individuals. Laboratory tests may show hemolytic anemia due to production of cold agglutinins against red blood cells. Another common cause of atypical pneumonia is Chlamydophila species, which include Chlamydophila pneumonia and Chlamydophila psittaci, the reservoir for which is birds. Legionella pneumonia, transmitted by contaminated water-based cooling systems, is another cause of atypical pneumonia. Prominent gastrointestinal symptoms, for example, vomiting and diarrhea, precede the pulmonary symptoms in Legionella infection. It also produces CNS symptoms such as confusion. It also causes electrolyte derangements such as hyponatremia and may also cause raised liver function tests. Lastly, community-acquired pneumonia is also caused by anaerobes such as Bacteroides fragilis, as in aspiration pneumonia. Infection with these anaerobes produces foul-smelling sputum. Let's proceed to clinical features of pneumonia. The classic features are fever, productive cough due to enhanced mucus production as an attempt to trap pathogens, dyspnea due to replacement of alveolar air with inflammatory fluid and the resultant impaired gas exchange, and pleuritic chest pain, which is sharp pain caused by respiratory movements and occurs due to involvement of the somatically innervated parietal pleura. Tachypnea and tachycardia are commonly seen. Another clinical presentation can be headaches, fatigue, malaise, and dry cough, which occurs in atypical pneumonia. On examination over the consolidated area, dullness to percussion is noted. This is because alveoli are now filled with fluid, which is less resonant than air. Since fluid is a better conductor of sound than air, enhanced breath sounds are heard during auscultation over the consolidated area. Also heard are rhonchi and crackles. Coming to diagnosis, chest X-ray is the best initial test to diagnose pneumonia. It helps exclude other lung pathologies and also gives a clue to the kind of pathogen causing pneumonia. The classic chest X-ray feature of pneumonia is consolidation of alveolar spaces. Lobar consolidation appears as abnormal lung opacification. Additional features that are often appreciated are air bronchograms, which refer to the prominent appearance of air-filled bronchi as they get surrounded by opacified alveolar spaces, as well as silhouette sign, which refers to the loss of interface between lung and soft tissues, such as heart and diaphragm. Many times, a peripneumonic effusion is also present, seen as obliteration of the costophrenic angle. Other radiological patterns of pneumonia include patchy consolidation of bronchopneumonia and diffuse reticular or ground glass opacities in interstitial pneumonia. This is a chest X-ray showing opacification in the middle lobe of the right lung. This is consistent with right middle lobe pneumonia. Note the sharp delineation at the junction of middle lobe with upper and lower lobes. This occurs because consolidation cannot spread directly across the fissures. Let's take a look at these two images of a chest X-ray. Image A represents a normal chest X-ray. Please notice the normal interface between right lung and other soft tissues such as heart and diaphragm. Image B represents a chest X-ray of a patient with pneumonia. We can clearly see the loss of previous normal interface and borders. This is known as silhouette sign. Let's also take a look at this chest X-ray. We can see the obliteration of left costophrenic angle caused by parapneumonic effusion. On the other hand, we can see a normal costophrenic angle on the right side. Here's an image showing multiple ill-defined reticulonodular opacities involving both lungs in an asymmetric pattern. This is consistent with patchy consolidation seen in bronchopneumonia. This chest X-ray image is showing bilateral ground glass opacity consistent with interstitial pneumonia. Other helpful investigations include sputum, gram stain, and culture to identify the causative agent. Legionella urine antigen test is a very sensitive and rapid test to diagnose Legionella pneumonia. For definitive diagnosis, sputum culture can be performed, as gram stain only reveals numerous neutrophils with no bacteria. In pneumonia, a complete blood count generally shows leukocytosis. However, white blood cell count may be normal in atypical pneumonia. Also, hemolytic anemia can be seen in mycoplasma pneumonia. Blood cultures are done when pneumonia is severe or when the patient is hospitalized. Arterial blood gases can also be done to evaluate respiratory function in severely sick or hospitalized patients. Let's reinforce what we learned with a quick review question. A 68-year-old woman is brought to the emergency department due to altered mental status and productive cough for the past 2 days. Her vital signs are significant for a temperature of 40 degrees Celsius and a blood pressure of 80/50. Cough is productive of purulent yellow sputum. What's the best initial test in the evaluation of this patient? This 68-year-old woman presents with altered mental status and productive cough for the past 2 days. She has a high fever evidenced by a temperature of 40 degrees Celsius and the hypotension evidenced by a blood pressure of 80/50. Cough is productive of purulent yellow sputum. This is a severe presentation of community-acquired pneumonia. The best initial test in the evaluation of the patient with suspected community-acquired pneumonia is chest X-ray. Coming to the treatment of community-acquired pneumonia, the first step is to assess the severity of pneumonia. This is done by using different scales or scores which use clinical features and laboratory results of patients to predict the mortality associated with the illness. The most common ones are the Pneumonia Severity Index and the CURB-65 scoring system. The parameters used in CURB-65 are presence of confusion, uremia, respiratory rate of 30 breaths per minute or above, low blood pressure, and age 65 or above. The higher the score, the greater the severity of pneumonia. Next, we determine where the patient should be treated based on the severity and risk of mortality. Mild cases are treated as outpatient with oral antibiotics. Moderate to severe cases are treated as inpatient with IV antibiotics and oxygen. And most severe cases with highest risk of mortality are admitted and treated in intensive care unit. Let's have a look at the CURB-65 scoring as an example. Each of the 5 parameters that we discussed earlier are given a single point and the total score for each patient is calculated. The higher the score, the greater the severity of pneumonia. So patients with a score of 0 to 1 are generally treated on an outpatient basis with oral antibiotics. A score of 2 indicates inpatient admission. A score of 3 to 5 warrants admission in intensive care unit. Next step is to administer antibiotics. Antibiotics are the mainstay of treatment of pneumonia. In previously healthy patients with no comorbid conditions and no use of antibiotics within the previous 3 months, the antibiotic of choice is a macrolide or doxycycline. These cover both the common typical and atypical pathogens. However, in patients with comorbid conditions or use of antibiotics within the previous 3 months, the risk of resistance to drugs is substantial. And so the commonly used regimen is either a respiratory fluoroquinolone, for example, levofloxacin, or a combination of a macrolide plus a beta-lactam drug. Other supportive measures include oxygen, if hypoxic, and fluids, if hypotensive. Complications of pneumonia include pleural effusion, empyema, which means pus in pleural cavity, lung abscess, sepsis, and acute respiratory distress syndrome. For prevention of pneumonia, one commonly practiced measure is the administration of annual influenza vaccines at the start of flu season. This reduces the incidence of influenza and hence also of post-influenza pneumonia. Secondly, pneumococcal vaccine reduces the incidence of pneumonia by Streptococcus pneumonia, which is the most common cause of community-acquired pneumonia. All adults aged 65 or above should be given the sequential PCV13 and PPSV23 pneumococcal vaccines. PCV is the pneumococcal conjugate vaccine, whereas PPSV is the pneumococcal polysaccharide vaccine. For those younger than 65 years, routine administration of pneumococcal vaccines is not recommended, except in those with comorbid conditions that would put them at high risk of getting severe disease. Specifically, adults less than 65 with comorbid conditions such as diabetes mellitus, smokers, alcoholics, and chronic liver disease should be given the PPSV23 alone. Adults less than 65 with very high-risk conditions such as asplenia, HIV, and chronic kidney disease should be given sequential PCV13 and PPSV23 vaccines. Next, we'll discuss hospital-acquired pneumonia. This is defined as pneumonia occurring after 48 hours of admission to hospital. The commonly implicated pathogens are gram-negative rods, such as E. coli, Pseudomonas, and Klebsiella, and Staphylococcus aureus, including the methicillin-resistant Staph aureus, or MRSA for short. Treatment includes oxygenation, fluids, and antibiotics. Empiric antibiotic therapy should always include gram-negative coverage, particularly Pseudomonas, as well as coverage of methicillin-sensitive Staphylococcus aureus, or MSSA. The commonly used drugs are a combination of piperacillin and tozobactam, levofloxacin or imipenem. Vancomycin, or linezolid, is to be included if MRSA is suspected. A second anti-pseudomonal drug, for example, gentamicin or aztreonam, is added if multi-drug-resistant Pseudomonas is suspected. Include coverage for both MDR Pseudomonas and MRSA if the patient is in septic shock, requires ventilatory support, or has had antibiotic exposure in the past 90 days. Ventilator-associated pneumonia is a type of hospital-acquired pneumonia. It's defined as pneumonia occurring 48 to 72 hours after intubation. It manifests as new infiltrates on chest X-ray, purulent secretions from endotracheal tube, fever, and increasing white blood cell count. For culture and sensitivity, tracheal aspirate or bronchoalveolar lavage can be done. Treatment includes gram-negative coverage, for example, aminoglycosides or fluoroquinolones. Vancomycin or linezolid is added when MRSA is suspected, and a second anti-pseudomonal drug is included when suspecting MDR Pseudomonas. Again, all three classes are combined if there is severe diseases. For example, the patient is in septic shock or has progressed to ARDS, or if there is history of IV drug use in the past 90 days. Importantly, ventilator-associated pneumonia has a very high mortality, and so prevention is extremely important. First of all, intubation should only be done when necessary, and patients should be weaned off as early as possible. So we should avoid unnecessary intubation. Additional preventative measures include proper hand hygiene and minimizing the risk of aspiration by head elevation, regular cleaning of supraglottic secretions, and minimum patient movement. Now let's discuss aspiration pneumonia. Aspiration pneumonia is pneumonia caused by aspiration of oropharyngeal or gastrointestinal contents into the lungs. The risk is highest in patients who cannot protect their airway, such as debilitated patients, alcoholics, and those with neuromuscular disorders. It's usually caused by a mixed aerobic and anaerobic infection, including anaerobes such as bacteroids, Peptostreptococcus, Fusobacterium, as well as aerobic organisms such as Staphylococcus aureus, Streptococcus pneumonia, and Pseudomonas aeruginosa. It typically has an indolent onset, presenting over days with classic pneumonia symptoms such as fever, tachycardia, cough with foul-smelling sputum due to anaerobes, and dyspnea. It can also produce lung abscess as a complication. Diagnosis is supported by chest X-ray finding of lung infiltrates in characteristic position. When aspiration occurs in upright position, pneumonia occurs in basal portion of right lower lobe. In supine individuals, it mostly occurs in posterior portion of right upper lobe or apical portion of right lower lobe. There is no specific treatment regimen. Common antibiotics used empirically are clindamycin or a combination of beta-lactam and beta-lactamase inhibitor. Let's conclude this lecture with a board-style question. A 47-year-old man comes to the physician due to fever and non-productive cough for 2 days. He has a past medical history of poorly controlled epilepsy, and his last seizure was 4 days ago. His vital signs include a temperature of 39 degrees Celsius, blood pressure of 110/80, heart rate of 89, respiratory rate of 22. Physical exam reveals dullness to percussion at the right lower chest. Laboratory findings are significant for a white blood cell count of 15,000, with 80% neutrophils. The chest X-ray reveals opacity within the apical segment of right lower lobe along with air fluid levels. Which of the following is the best treatment option for this patient's condition? A. Aztreonam, B. Gentamicin, C. Vancomycin, or D. Clindamycin. This patient presents with fever and non-productive cough for the past 2 days. He has a fever of 39 degrees Celsius and tachypnea evidenced by a respiratory rate of 22. Laboratory findings are significant for a white blood cell count of 15,000 with 80% neutrophils. The chest X-ray reveals opacity within the apical segment of right lower lobe along with air fluid levels. All these findings are classic for bacterial pneumonia with lung abscess. This patient has a past medical history of poorly controlled epilepsy, and his last seizure was 4 days ago. He likely aspirated his oropharyngeal flora during the seizure, leading to aspiration pneumonia. Since the oropharyngeal flora mainly consists of anaerobes and gram-negative bacteria, the optimal treatment option for this patient would be clindamycin. Clindamycin covers both anaerobes and gram-negative bacteria. Therefore, the correct answer is option D. Here's a slide reminding us of the treatment regimen for aspiration pneumonia. Let's discuss why other options are incorrect. Option A, aztreonam, and option B, gentamicin, are incorrect because monobactams and aminoglycosides are only effective against gram-negative aerobic rods. They do not effectively cover anaerobes. Finally, option C is incorrect because vancomycin covers only gram-positive bacteria. In contrast, the oropharyngeal flora, most likely responsible for this patient's aspiration pneumonia, mainly consists of gram-negative bacteria. And that concludes our lecture on pneumonia.